My presentation was on fertility issues in breast cancer patients undergoing an adjuvant treatment. And of course this is an important topic because a lot of patients are diagnosed below the age of 40, and for this reason they are facing the problem of gonadotoxicity of anti-cancer treatment, which have the possibility of permanently damage their ovarian function. We know and we have now a lot of data indicating that pregnancy after breast cancer is safe. So we have a lot of case control studies with long-term follow-up indicating that pregnancy after breast cancer can be considered safe, both in the hormone receptor positive and hormone receptor negative patient population. So there are now a clear consensus on recommending fertility preservation counseling to all premenopausal patients undergoing anti-cancer treatment. Unfortunately, breast cancer patients have the lowest chance to become pregnant after diagnosis as compared to the other population of cancer survivors. And this might be a combination of age at diagnosis and the risk of toxicity from anti-cancer treatments. We know that ovarian function and ovarian reserve decrease over time, and the risk of permanent failure of ovarian function is dependent by the age at the starting of chemotherapy and, of course, by the type of chemotherapy. Nowadays we have a lot of strategies to preserve fertility in breast cancer patients, and including oocyte or embryo cryopreservation, ovarian tissue cryopreservation, and also the possibility of inducing a temporary ovarian suppression with GnRH agonists. The embryo or oocyte cryopreservation are the preferred choice for these patients. Ovarian tissue cryopreservation is still experimental because there is a risk of malignant cell contamination of ovarian tissue, so nowadays should be reserved only for prepuberal girls. The possibility of temporary ovarian suppression with GnRH agonists should be considered for the majority of our patients, because we have a lot of data indicating that this strategy is associated with a lower risk of permanent ovarian failure as compared to control, and also an increase in the rate of pregnancy after treatment as compared to control. This cannot be considered as a substitute for embryo or oocyte cryopreservation, but is something that should be discussed with all the patients who are interested in maintaining their ovarian function. So we can conclude that it is important to stress the fact that pregnancy is safe after breast cancer, so there are no reason to deny the possibility of a pregnancy in breast cancer survivor. So for this reason it's important to discuss the possibility, all the strategies for preserving fertility in young breast cancer patients, and of course it is critical early referral to the oncofertility team to avoid delays in starting anti-cancer treatments. It depends nowadays. It's also depending from the national health system. For instance, in Italy, it comes for free in breast cancer patients. We have, however, only the possibility for oocyte cryopreservation and not for embryo cryopreservation. But it's important to discuss all the options with the patients independently from the parity. This is not available in all the institutions. Big centers have the possibility to offer all these strategies, so that's why it's important to early discuss and early refer the patient to the proper institution. And in this perspective, the GnRH agonists are very cheap and they can be offered to all the patients, so that's why it's something it's important to discuss with all the patients.